Welcome back everyone to the second technical session. We will now start with the plenary lecture. Biostatistics is an invaluable tool which helps in understanding a disease better. Our speaker, Professor Selvarat Sivasubramaniam, is here to enlighten us about the biostatistical aspects of COVID-19 pandemic. Participants, please post your questions in the Zoom chat box or in YouTube live chat. I invite Dr. M. Kavita, Assistant Professor, Department of Biochemistry, to introduce the speaker.
Thank you, Jayalakshmi. So good afternoon to one and all present here. I would like to introduce the next guest speaker of the day. Interestingly, the next speaker is an expert in epidemiological statistics and public health. He has completed his master's degree at the Christian Medical College, Vellore, followed by PG Diploma in Computing at American College, Madurai. He has completed a PG certificate in teaching in London. He currently heads Stat-Home Research Consultancy, UK, specializing in statistical analysis and data management solutions. He has over 25 years of experience in design, conduct, and analysis of research studies, both in low to middle income country and developed country settings. He has previously worked at leading organizations like Arvind Eye Care System in India, University of Aberdeen in Scotland, London School of Hygiene and Tropical Medicine, and at Imperial College London in England. He has published around 60 to 70 scientific papers in peer-reviewed journals based on topics like blindness, childhood malnutrition, sport injuries, asthma, suicide, and cancer in the United Kingdom. Ladies and gentlemen, may I now invite Professor Selvarat Sivasubramaniam, sir, to deliver his plenary lecture. Over to you, sir.
Thank you for the introduction, Dr. Kavita. Can you hear me very well? Hello?
Yes, sir.
Yes, sir. Yes, sir. We can hear you.
Okay. Thank you very much. Thanks for the introduction. And good morning. Well, good morning from UK and good afternoon to everyone in India. I'm very happy and it's really an honor to join this international conference on the infectious diseases in an era of vaccines. I'm really appreciate the organizers and the patron of DG Vaishnav College to make this event a reality. So today I'll be talking about the biostatistical aspects of COVID pandemic. I'll share my screen. Please see that whether you can all see that. Sorry, just a question. Is it the slides will go up or roll up on your side, or is it something like I need to do from here?
Yeah, if you are comfortable, you can do it from your side. If you want, we will do it for you.
I can do it from here. That will be comfortable for me.
Easy for you. Yeah, so you know how much you can talk on each slide.
Yeah. So I'll be sharing the screen. Is that right?
Yes. Yeah, you share your screen. Yes, we can see your slide.
Yeah, that'll be great. Okay. Yeah, so obviously the COVID epidemic is one of the, it's the biggest catastrophic event we had in the recent times. And since then, the lot of research and development has been evolving in a very rapid way to understand the epidemiology of the pandemic. And in this talk, I'm just going to outline some of the issues and challenges on a statistical aspects, how we help in the research and development aspect of the COVID pandemic. So I should tell you at the outset that I'm not an infectious person, disease person. I have worked in the past on eye-related infections, but having said that, I'm a statistician, and my interests are particularly in the data collection, analysis, and interpretation of the COVID pandemic. So what I'm going to talk about today is some of the aspects, like how the modeling helped to inform the policy, both for the government and healthcare agencies. And when we are in the need of vaccines and the therapies, what are all the novel designs, statistical designs were used to develop the therapies? And of course, diagnostic tests have been really helpful to identify who really got the disease. However, all these things have been done in a very rapid manner. So I'll be talking very briefly about the evolution of a diagnostic test. The healthcare data we collect, that is not complete without the social care data. So what are all the issues we faced in conducting the social surveys, both in the data collection and analysis? And last but not the least, the communicating the risk. So how the public and educators and all the policymakers should be communicated the risk of a COVID pandemic, and finally some of the lessons to learn from this COVID epidemic. So I will try to cover in 30 to 40 minutes time, and if you have any questions, we can discuss at the end of the session. So first is the modeling to inform the policy. Several groups actually involved in modeling because when at the start of the epidemic was going ups and downs, and we wanted to know that what is actually going on and who is getting the disease. So several groups, whether it's in India or UK or United States, were working on statistical modeling. In India, obviously, it's the ICMR and some other groups. And in United Kingdom, notably, Imperial College London and the London School of Hygiene and Tropical Medicine, and of course, the University of Warwick and other government agencies were working on the data modeling to see the spread of the disease. And in the United States, notable institutions are the Johns Hopkins University modeling group and the University of Michigan group made a real impact in the decision making. But the real issue we had at the start of the epidemic is that we don't have much data to do the modeling. Particularly, we really did not know that who actually got affected. I mean, the number of truly affected cases. So in the absence of lack of data with a lot of assumptions, we had to do the modeling because we need to do what we have best at hand in order to make the informed decisions. Also, at that time point, there is no approved pharmaceutical interventions to consider as well. So these are all the complexities we had at the beginning of the pandemic, yet we went ahead doing the modeling of the data. So all these groups, they all used a data-driven approach in order to answer the following questions. In the beginning of the pandemic, we really didn't know that what will be the effect of it. It is not that government or other healthcare agencies messed up the problem, but it is the realization that if we can't do something about it, then we will end up with a situation something like Wuhan, China. So it's an urgent need, and a lot of and many groups are involved into the data-driven approach to the data modeling. So they try to answer at least the three major questions. When the epidemic is on the rise, what can we expect in the next few months? Because that is important for the government as well as for the public and for the policymakers and for the healthcare agencies to decide upon how well they can allocate their resources. And how will this affect the general public? So when we talk about the general public, it is not only the health aspects, but even the economic and other livelihood aspects as well. And finally, how the government and the people prepare for this crisis. Again, it is not allocating just the healthcare resources, but also how to help people with incentives in order to sustain this epidemic period. So these are all the questions. They essentially try to answer it. I try to illustrate just one data modeling approach which is used in United Kingdom. This was done by the Professor Neil Ferguson group at the Imperial College London. So at the start of the epidemic, they built a lot of mathematical models in order to inform the government. And one particular report is that report number 19. It looked at the impact of non-pharmaceutical interventions to reduce the COVID-19 mortality and healthcare demand. I think you can all see the graph. If you look at the graph A, it shows the what we can expect in the number of COVID cases if we don't do anything. That is the black line. Hello.
Participants, please kindly mute your audio. Ms. Vaishnavi, kindly mute your audio.
Yes, if you look at the graph, the black line have a steep increase after April onwards. Suppose if you don't do anything about the the pandemic, the number of cases are sharply increased after April 2020. And there are another scenarios. Suppose if we do the lockdown, I mean, particularly the social distancing, that is the brown line, then it decreases dramatically. And the school and university closure, it does not have a big impact, but then it postpones the epidemic. And the graph B is the magnification of the bottom line of the graph A. So the important line here is the red line. So the red line is the surge in critical care facilities. Hospitals or the critical care facilities here have a certain level to take care of the demand in case if there is an emergency. But in the time of COVID, as the graph shows, if once it breaches the red line, then the hospitals cannot cope. So the government has to step in and have to take a drastic steps to take care of this situation. So this graph was, this analysis was based on the data available then. And then the projection really helped the government. And this particular graph was submitted to the government on 16th of March. And within a week, the government announced a complete lockdown in UK. So the data modeling the epidemic is really helpful to make the decisions for the government. And a similar situation for the India also. So this particular graph, this was developed by the Johns Hopkins University. So as you see, like in any other place in the world, the pandemic starts slowly in January. Then once it enters slowly, then after that, there is a exponential increase after some time. Particularly after a sudden increase happens after March 7. onwards. So this, along with the following graph I'm going to show, the government, it helps the government to decide on the complete lockdown on March 24th in India. So this is the another graph by the Johns Hopkins University. If you look at it, they have done it the similar way what the Imperial College has done. So the cases rise dramatically after April, and in India, it's fortunate that we are a little bit ahead of to announce the lockdown at the phase 1 of the epidemic. So moving from modeling the epidemic, now we look at the trials of the therapies. As I said, at the time of the COVID pandemic, at the start of the pandemic, there is no approved vaccines or the therapies at that time. So it was an urgent and immediate need that we need to develop therapies. But then there are problems in the clinical trial designs using a conventional clinical trial designs. So I'll just go a little bit in detail about these designs here. The conventional clinical trial design, it tests a single treatment, and particularly in a homogeneous population. But as you see in the COVID pandemic, the population is obviously heterogeneous. The different cultures, different places, different age, sex strata, and a different socioeconomic status, urban rural classifications. And it's a widely heterogeneous, and it's very difficult to do. I mean, the randomized clinical trial, the conventional trial design will not help to answer for such a population. And basically, these conventional clinical trials are based on using just one particular population and one particular drug, and answering for only one disease strategy, which is also not helpful because obviously the outcome is for this particular COVID pandemic is like multiple organ failure and other problems. So it's very difficult to study using the conventional clinical trial designs. And apart from that, the randomized clinical trials, I mean, the conventional designs are not helpful to deal with the multiple diseases at the same time. And having done all those things, these trials, there is no guarantee about it. The clinical trials can fail at any phase of the study. For example, it might happen, it may be unsuccessful at stage 2 or stage 3 or stage 4 clinical trials. So we need to really use some novel method rather than using a conventional clinical trial designs. And one such clinical trial design is that I'll talk about that. It's about the adaptive trials. So, but before going into that, the questions actually we need to answer for the therapeutic intervention is that we should be able to compare multiple interventions because everybody is looking for a drug. So we should be able to compare the multiple intervention at the same time, or some treatment combinations together at the same time. And as I said, because the population is very heterogeneous in terms of the demographic characteristics and in terms of the disease severity, and in terms of who got it, who did not get it, who is susceptible. So we should be able to do the study in a heterogeneous patient population. And even if we do that, we should be able to get a valid effect estimates across the subgroups. I mean, we need to have each subgroup, we need to have an effect estimate with the necessary statistical confidence. So we should be able to generate separate effect estimates. And as you all know, the conventional clinical trials usually takes a lot of time to complete. So, and suppose if you are trying one particular intervention, we have to wait for that to complete it. And then if it doesn't work, then we have to develop another one. So it's like a more of a sequential design. So it's very bit difficult to wait for such a long time, particularly when we are in an emergency situation. So we need to minimize the downtime between the trials. And also, like as and the new knowledge and the new evidence emerge, we should be able to add new treatments in the existing design as it progresses. So these are all the needs we had in order to come up with the uh, a therapeutic intervention for the pandemic. But all these questions is very difficult or costly to answer with the conventional parallel group randomized clinical trials. So what the novel trial they used is the adaptive trials. So the adaptive trials, I'll just explain a little bit. So in a conventional clinical trial, uh, we design the study first and then we conduct it. And once the data is collected, we do the analysis. It's more of a sequential pattern. Whereas in the adaptive design, after the designing the study, during the conduct of the study, based on the evidences we accumulate, we can review it and then make the necessary changes. Suppose if we see that one particular treatment is not working well at the interim analysis, we can either discard it or we can reduce the number of participants in that particular arm, and we can include more participants in a promising treatment arm. So we can adopt and then we can continue the study. And this is a loop that we can keep continuing the study and then we can review it. Based on the review, we can adopt and make changes without losing the statistical power and the confidence of the effect estimates we are about to estimate. So this is an ongoing thing. So this adoption, that's what it makes us like a adaptive trials, an important trial design. So there were many key trials across the world, and because I'm in UK, so that I'll just mention about the key national UK trials. There are 3 trials to note. One is that the principal trial, which entirely focused on the higher risk patients in the primary care trial. So in UK, the health setup is that there is a primary care, like everybody has to go to the primary care physician first before accessing the secondary care. So this principal clinical trial focused on the higher risk patients in primary care. The second one is the recovery trial, which is only all those who have already been admitted in the hospital. So it's a hospital-based trial. And finally, the important one is the REMAP cap. This is focused on entirely on the critically ill patients. I'll go a little bit in detail about this REMAP cap, just to illustrate that how the current clinical drug designs are novel. So the REMAP is the randomized embedded multifactorial adaptive platform. So it's a randomized trial, and many treatment arms and therapies are embedded in the trial, and it's a multifactorial trial. So it's not only a single treatment or therapy, but a combination of therapies to see the multifactorial effect of the therapies. And as I mentioned earlier, it's an adaptive trial, so it's adaptive as it progresses. So as it progresses, when we have based on the interim data we collect, we can include more arms, or we can discard some of the arms, or we can make modifications without losing the statistical power of the study. So this particular design, so it's a randomized trial. So it's a randomization. It's a randomization at the same time. It's allowing for the causal inference as well, and embedding of study procedures into the routine care processes. So it is not something like an ideal situation we don't create. Instead, it is the routine care process where we have a primary care patients or a hospital patients or those who got the diseases. So it's like in a routine care, we can embed the study procedures. So that is the big advantage of this REMAP platform. It's a multifactorial model comparing the multiple intervention across the subgroups. So we can have many subgroups rather than a single population as in conventional clinical trials. We can have many subgroups. and we can compare the multiple interventions. It's a response adaptive randomization with the preferential assignment. So it's based on the response. Suppose some treatments, some therapies is not working, then we can change the allocation ratio to the particular treatment arm, and we can make the preferential assignments. And all these things can be designed in advance, or as it goes. The sample size calculation and other things we can do as the study progresses. It's a platform to permit the continuous enrollment beyond initial treatments. So even though the study is initiated for a particular related disease, but as it progresses, we can continue the enrollment, adding more and more arms in order to answer the current health issue. In this case, it's the COVID pandemic. So this REMAP CAP is that particular trial where in the REMAP platform, the adults with the community acute pneumonia, that is CAP, they're included in that. It is a phase 4 clinical trial, and it is well regarded as the most important key clinical trial for COVID-19 in UK and some of the other countries where it is taking place. So it's still continuing in Europe, including United Kingdom and Australia, New Zealand, and with the recent funding, it's been enrolling the patients in Canada as well. So as I said, this trial has got multiple combinations of conventional care and experimental treatments as well. So we can evaluate the care which is already ongoing, as well as some of the treatments which is in experimental in nature, we can include in that. Okay. So the primary outcome of this trial is the all-cause mortality at 90 days. And with this REMAP CAP, the pandemic appendix to the core protocol is included. So this pandemic appendix has got four different arms, which I'm not going to go in detail here because we have a little bit short of time, but details are available on the web. If somebody is interested, they can look at it. The interesting thing is the funding is from the government grants from multiple countries, because in a conventional clinical trial, it's very difficult to get from the government grant, particularly when we don't know that we need to wait for a longer time, or we have the probability that the conventional trial can fail at any stage of the development. So usually the government grants are very reluctant to support for that. Whereas in the REMAP CAP, because its adaptability nature, it's easy to get the government grants, and particularly from multiple countries. So this is one important aspect. Rather than depending on the conventional clinical trial designs, this COVID pandemic has challenged us to use adaptive trials in a big way, and these adaptive trial platforms are becoming popular because of the COVID pandemic. So the next one is that the evaluation of the diagnostic test. So when at the start of the epidemic, we really did not have a proper diagnostic test. So everybody had to decide whether they got the disease or not, just based on the symptoms. So there is a big uncertainty about whether somebody has got the disease or not. So in a rapid way, like there are a lot of diagnostic tests were developed, but because it was rushed at the beginning, and there are a lot of controversies also along with that. So we statisticians, we understand about what is the sensitivity and the specificity and what are the other statistical parameters in order to evaluate a diagnostic test. But this need to be passed on to the all those stakeholders, the public or the healthcare providers or the government or the policy makers or the decision makers. They should be able to understand how to evaluate a diagnostic test. I'm not going to go in detail about how to evaluate a diagnostic test, which itself will require a separate talk. But there is a very good article. Well, it's a report from the Royal Statistical Society on how to evaluate the diagnostic test. So the Royal Statistical Society, in response to the COVID pandemic, they set up different working groups, and one of the working group is the diagnostic test, and they developed this report, which is available free on the internet, and you can go through. So basically, this report gives the background about infectious diseases and about the diagnostic test to understand, and what are all the scientific basis needed in order to evaluate the test, and the population being tested, whether it's a homogeneous or heterogeneous, what type of population being tested, and the statistical parameters required for reporting. So both the analytical performance as well as the clinical performance, what are the parameters that requires for the reporting. And at the end, it gives recommendations that on the study designs, how the study should be designed to evaluate a diagnostic test, and what are the regulatory matters. It gives the recommendations about that, what are the things that should be taken care by the regulatory agencies. And finally, it gives a very good recommendations about the transparency matters. That is, what the public need to know and what should be in the public domain for everybody to see, whether it is the public or the patients or the clinicians or the policymakers. So what information should be available publicly? And if it is a research, what information the researchers should know and the study participants should know. So it's a very good document, and I would urge that anybody is interested in how to evaluate the diagnostic test, they should read this, because more and more diagnostic tests are coming up. At the start of the epidemic, there was no diagnostic test, and as it arises also, it was difficult to access those tests. But now it's everybody's getting the test, just like you can buy a medicine over the counter. But what about the validity of this diagnostic test? So I think people, that the patients or the public, they should be aware that how to evaluate the diagnostic test to some extent. So in that respect, this report is a very good report that everybody should have a look at it. And the social surveys, the social care data, which is very, very important, because without which healthcare data is incomplete. So normally there are a lot of social surveys are being conducted, whether it's in India or worldwide. And these surveys are sometimes it's a cross-sectional surveys, and sometimes it's a continuous surveys. And generally these are all large scale surveys. They go and usually they do it's a face-to-face, going and seeing the participants and collecting the data. In India, there are a lot of non-governmental organizations also do a professional large scale surveys on a continuous basis. So these surveys are all based on a probability sample. It is not like in a haphazard going like a place to place and collecting the data. So a proper scientific based probability sample is collected. And the COVID situation has created a big problem for that in order to access this probability sample. So because of that, and there is a big drop in the response rate as well, because of the lockdown or because of the you have to stay away from people, you have to maintain a social distancing. So the response rate has dropped a lot. So I will discuss in detail about each one of these. So this in turn creates the sample bias. So it is not that what we intended to study and what we get after this social distancing and the lockdown is not what we intended to study. So that leads to a sample bias. Of course, statistical methods have got weighting categories in order to adjust for the sample bias or for the response rate. But in order to do the weighting properly, then we need to have some additional information, which is difficult to get in the sense of face-to-face interviews. And above all, this social distancing lead to rethink about how far the length of the questionnaire should be there, and the complexity of the questionnaire and how to word the questionnaires. So I'll just go a little bit in detail about each one of these here. So the advantage of a face-to-face, I mean, before the lockdown or before the social distancing, is that when we do the face-to-face interview, we get a very good response rate because the investigators meet the participants and then they talk to them, and which increases the response rates. Some of the larger scale surveys I involved in India, we used to get up to like 85%, even 90% of response rate. So which reduces the sample bias in the sense that so if you lose like about 10% of the sample, like we are not able to study, that's kind of okay. We can manage that, and we can do some statistical adjustments for that. But in the case of the social distancing, this response rate has gone down greatly. The another thing is that the face-to-face survey, it allows a lengthy, detailed questionnaires. Suppose if it is a comprehensive clinical questionnaire or comprehensive questionnaire about a social status or something, then you can have a very lengthy, detailed questionnaires, and you can explain the questions to the participants, and you can get a very good response as well. And it avoids the risk of mode effects. By the mode, I mean that in the absence of a face-to-face, then we'll be using different methods like web surveys, or even the calling through the telephone, like the telephone surveys, or using the telephone or web together. So these kind of different modes we can use it, but there, excuse me, they're like the different modes gives different response rates. So those are all called like it's the effect of the different mode we use. It's the mode effects. So in a face-to-face survey, we don't have such problems. And above all, the face-to-face surveys allows a collection of objective measurements. Suppose if you want to take a blood pressure, or if you want to measurement like in anthropology, measurements like a height, weight, mid-arm circumferences, and other measurements, or so even some clinical measurements like a visual acuity or some other clinical measurements you want to take it. It is easier to do it in the face-to-face survey, which is not possible in, or it's difficult in other type of other modes of surveys. So the social distancing has really created a problem to conduct the face-to-face surveys. So in that case, then what should we do? Whether should we delay the data collection in social surveys? And if we are delaying it, how long to delay? Because we never knew that how long the lockdown will continue, and whether to continue the delay the data collection, or we have to start it altogether once the lockdown is lifted or the social distancing is removed. We didn't know. It was a big ambiguity at that time. And continue the data collection even during the lockdown or even during the social distancing policies are in place. And if we have to do that, we have to use a different method. And as I said earlier, different methods obviously will bring in different mode effects. Or altogether, we have to collect a new data collection. We have to find a new way of collecting the data, and the questionnaire and everything has to be redesigned and everything. So maybe it may give like a new high quality evidence. So these are all the issues we had when we had the lockdown policy was in place. At the same time, we also have to make sure the safety of the interviewers as well as the respondents. And there is not a much need. There is a need for the flexibility as well, because when the social distancing was in place, or when the lockdown was in place, it is very difficult to contact the respondents. So we need to adjust with their timings and then their availability. So that was an issue when we had this lockdown policy in place. So now the challenges now in this pandemic situation, there are other alternative methods whether we could go for that. The one is that we can go to the web surveys, and I remember very well that once the pandemic has started, there is a surge of many web surveys. I mean, of course, including myself, we did a web survey and that. But the problem is that the response rate is very low in web surveys. Let us say that it's only around 15% on average, which would create a huge sample bias. because the 15% sample may not be the sample we intended to study. So that will create other statistical issues. So whether we can start the web surveys continuously, or we can just use the web for the existing respondents as a follow-up study. We can do that. So we can use it as a follow-up mode, or we can start completely as a web-only surveys. And other alternative is that we can use that computer-assisted one. This is mainly used in the Western countries like United Kingdom and United States to a large extent. Or in India, we can contact them through the telephone, or we can develop an app to ask them to fill in the questionnaire and other kind of things. Or we can contact the respondents through video calls. Again, the response rate is not that great as it is similar to web surveys. In fact, it is even a little bit less than the web surveys. It is about only 10 to 12% in the video calls or the CATI method. Or we can use a combination of both web and CATI. So we can use the web survey, and then we can follow the respondents, follow up the respondents with the subsequently with the video calls. So these are all the challenges, and I think it's not only big. I mean, after this pandemic situation, I think people are more and more going towards the web surveys because it's easier to collect, and the technology has improved a lot since then. But the real issues are there in terms of the sample bias, and then the mode effect and other statistical issues remain with that. So if we go for those other different modes, the problems in the findings, in the final results, I'll just explain a little bit in detail about that. So as I said earlier, it is the mode effect we will end up with. We're using a different method. First, we don't know that the sample is the one that we actually wanted to study because of the low response rate. So which will end up with a measurement error. So if it is a different methods are giving different results, so it means that it's a measurement error. Okay? And in the sample design also, doing a random selection is a bit difficult. Either we can go by the address or we can go by the phone numbers, but it is not as like in a geographical random selection. It is not that straightforward. So there are issues in the random selection, which will lead to a sample bias. So whether the sample we selected, is it the true representative of the population? That's a big question if we don't use the face-to-face methods. And this risk of bias, it increases with the lower response rate. As I mentioned, this web surveys gives only like around 15%, and even the telephone interviews and all those things will only around 12% or something, because it's very difficult to catch the respondents through the phone by phoning them. So the risk of bias increases with the lower response rates. And because these web surveys or the telephone interviews, the interview has to be short. And it's difficult to get some additional or auxiliary information as part of the survey, which is very necessary for giving the weights of the estimates in the results. So because we get the reduced information for the weighting, we can... Thank you. Because we have the reduced information for the weighting, it is difficult to do the proper statistical adjustments before publishing the results. And obviously, it has gotten a big impact on the time series. Time series in the sense, when we have a continuous survey, then when we lose a particular time point, then it's difficult to continue the study, or it's difficult to make the proper estimates. And above all, this pandemic has got a big effect on the people's attitude and their behavior. People who are interested in the studies earlier, they become reluctant later, and the people move. So there are a lot of issues we have on the as part of the pandemic effect. So these are all the issues in the presence of social distancing and lockdown situation. So what are the opportunities for that? So the one way is like we can go for the different methods, and we can, as I said, like we can use the CATI method, or we can use the telephone interviews, we can use the video calls, kind of different way of data collection. or we can use a combination of these methods. So it's a really try it out. There is a potential for the hybrid model. Even the pandemic is over, and I think probably people are slowly adopting for the other methods as well, as I mentioned, web surveys and other methods. So there is a lot of potential. This is one of the opportunities. I think we should say that after the pandemic. And we can use that more use of a follow-up studies. Instead of a continuously following, we can have a many cross-sectional studies to continue with it, because the technology makes it easy to collect the information. And there is a lot of scope for the methodological research to assess the impact of these different methods. Both the impact, what different modes it gives, different estimates, and how far we can rely on the different methods. We can do a lot of methodological analysis. Having said that, the researchers, in my experience, most of the researchers are keen to return to the face-to-face surveys, but COVID pandemics obviously has changed the game, and the technological advancement. I think, particularly in India, there will be more and more use of technology to collect the data in a different modes. So having got the results and all the social survey data, all the modeling data and everything, how to communicate the risk to the population? So it's very important, because I will talk a little bit later on that, because the risk of a pandemic is it's a lot of disinformation, not only in the newspapers or in the web or even the day-to-day conversations. It's a lot are based on our own political side and our own ignorance about the risk. So the numbers are keep changing. So in order for make the people really understand the pandemic risk, the one method suggested is that we can use the normal risk. So how this pandemic risk compares with the normal risk of dying. Okay, so we can use the death rates in the population, see that how it changes as people with age. So age is a stronger risk factor for COVID as well. So we can show that. And what will happen if we what will happen if you catch the COVID? So the chance of dying if you catch the COVID is really doubles. I will show it in a graph in the next slide. So the good visualization helps to learn more from the graph. So people easily understand from the graph rather than by the numbers. So this is one important graph published by Professor David Spiegelhalter and the BMJ. This is the observed population fatality rates for nearly 50,000 deaths mentioning COVID-19 within a very short period of time, like between March and June in 2020. I will request you to look at the top graph. It is on the logarithmic scale. There are two sets of lines are there. The one is that the one of the dotted lines are based on the normal risk. I move my cursor. I don't know whether you're able to see it. So the normal risk, if you see it, it was in the beginning is a very high because of the pregnancy complications and the infant mortality. Then it slows down and then it increases as the person is getting old. It increases. The COVID also, it's for the younger population it is less, but as it increases, it goes as a higher also. And if you look at it, the size of the risk is more or less the same as like a normal risk. It means that we got equally the same risk of our normally the risk of normally dying. So it's actually the double the risk. And if you look at very clearly in the linear scale at the bottom of the graph, it's the linear scale. So it is it starts with a smaller. It starts with a smaller prevalence, but then it increases dramatically after 50 years of age. So graphs like this really helps the public and the policymakers to understand the risk of the COVID, which will be really helpful for them to make informed decisions. So data does not speak for itself. Like we have to make an effort to for the public to understand the risk. So the data has to be made accessible and accessible by the citizens. This is one of the thing that the government has to take care, or other healthcare organizations should focus on that. As of now, or even immediately after the COVID pandemic started in India also, the data is not publicly available, which made it very difficult for the researchers from the different healthcare agencies to assess the problem. So the data should be made accessible, and it should be accessible by the citizens. And other thing is like we should be able to make use of the available data. So even the data is available, we should know that where the data is available, and we should be able to make use of the available data. So the government has to really think about to facilitate the data linking, how we can pull the data together and put it in a particular place so that anyone can access and assess by themselves. And in addition to all these things, statisticians or the epidemiologists and others who are involved with the uh, uh, numbers, I think they should go out and then educate the public as a social responsibility. Because in the absence of that, people get a different pictures and different prejudices. So the educated people who are involved in the research should take a step forward to get involved in communicating the risk. So finally, what are the lessons government can learn from this pandemic? So the government has to really invest in the public health data. As I mentioned earlier, the data was not available immediately or even after for some time to make a proper estimation or projection for the decision making, particularly in India. So the government should invest in more in public health data, and it should publish evidence frequently. And it should be clear and open about the data, because it should not be restricted to a particular organization. It should be open to all the research organizations or the public who are interested. They should be able to assess it and analyze it. And also, the government should challenge the issues of statistics, because there is a lot of rumor and a lot of misinformation at the beginning of the COVID pandemic, and which unnecessarily put the public in trouble. Whether it is social media or even to some extent as the newspapers. So the government should make a serious steps about to challenge the issues of the statistics. And of course, media also has to step up its responsibilities rather than just to increase the viewership. And the decision makers, they should be made numerate. They should understand that what are the basic statistical terms, statistical parameters. They should understand those things. So we should make the decision makers aware of some statistical skills. That's also important in a situation like a COVID pandemic. Finally, is the government should be able to build an effective infectious disease surveillance system. So one thing is that the disease has increased, and it's again it goes up and down at some places, but a continuous surveillance system is very important for the country. And as I said earlier, there are so many new diagnostic tests are coming up, and there should be they should increase the scrutiny of this diagnostic test, and there should be openness about its sensitivity and specificity of this test. That's also an important issue. So health data is incomplete with the social care data. I think the government has to make steps to continue with the existing social surveys. And above all, the evaluation should be the main interest of the policy. So the government can implement the policies, the decisions can be made, but whether these policies works or not, whether they have been evaluated or not, that's a big question. So the evaluation should be put at the heart of the policy. So as a summary, so I tried to just to give an outline about how the different statistical methods, what are the issues we had, and what are some new novel methods used for modeling to inform the policy and for the decision makers, and a novel clinical trial design, which is an adaptive platform to compare the therapies, and the need for the evaluation of the diagnostic test, and the information available for to evaluate the diagnostic test. I briefly outlined for that. And the social surveys, as I said, this is very, very important as part of the healthcare data. So how to continue in the presence of public distancing and lockdown, and how to continue with the surveys with the different methods. And finally, that how we should be knowledgeable, and then we should be responsible to communicate the risk to the public, and finally to the lessons to learn. So I think I will stop with this note, and if you have any questions, you can ask me. And thank you for that. And if you don't have any questions now, or if somebody wants to contact me later, I have given my email address as well. Thank you very much.
So we have questions in the chat box. Would you like to take it up?
Okay.
So there is a question. So can you hear me, sir?
I can hear you, but I'm trying to, maybe I'm not able to access the, maybe you need to.
Yeah, yes. The question: how to cope up with COVID-19 mental stress? There is a question put up by Prasanna Kumar. How to cope up with COVID-19 mental stress?
Yes, the mental stress actually is a big issue, because many of them has lost their kith and kin, and particularly the job loss and the economic situations. I'm not sure about that, how this is being done in India, but in the UK, we have the system to have we have the peer groups to discuss about that, and then government spends a certain amount of money to contact to get the counseling immediately. I think it's to be active, and then to get to with the peers, and if necessary, then it's to get a professional advice. I think that is the best way to go, rather than just worrying about themselves.
Yeah. Okay, so there is another question from Roshni. Is there any side effects in immune responses due to COVID-19? In the chat box.
I think I'm not the right person to answer that, because I'm not an infectious disease person per se. Maybe some infectious disease people, it's not a statistical thing. So I think some infectious disease people can best answer that question.
Maybe I have a question like, what is the probability of having third wave in India? Because statistics.
Anywhere, even in world also we can.
Yeah, it's the scenario is keep changing. Again, there is a lot of a debate about whether to continue with the social distancing. And if you release the lockdown early, then it has gotten a adverse effect later as well. And myself, like I've been on and off to India and the UK, and I've been struggling to during this COVID period to travel. So in some places in India, like we take the situation seriously, we put the lockdown and release it later, whereas in UK it's on and off. It's actually $1 million question, I would say, because of the changing scenario and the models suggest. But there would be the general idea and the general expectations is that there will be a third wave. It may not be as serious as the first two, but obviously there will be a third wave.
Thank you, sir. Thank you. Yes. Any more questions from the audience? Yes. Audience, any questions?
Yeah, I think there are no more questions.
Yeah.
I try to give a more of a general picture about the statistical issues here, but I deliberately did not want to discuss anything in particular about anything in any big project or anything, partially because of the lack of time. But if anybody is interested, they can always contact me by email. Thank you.
Okay, sir. So, sir, on behalf of everybody present here, I thank you for your wonderful insights on biostatistical aspects of COVID-19. I am sure everyone here, everyone now would have far more understanding of the different aspects of data collection, like REMAP and then advantages of face-to-face social survey and the challenges associated with data collection during pandemic, etc. that you have brought to our to this platform. And also to add upon, I particularly liked your comment on steps to be taken towards pooling the data at one place regarding like data bank, a sort of data bank. I really appreciate that you took the time to be here with us. Once again, sir.
Thank you very much. It's a pleasure for me to join the conference.
And with this, the end of plenary lecture series of day 1. Next, we have in the queue oral presentation slot 2 by our participants. Over to MC.
Thank you, ma'am. Let us now continue with the last session of the day, paper presentation. Science knows no country because knowledge belongs to humanity, and it is a torch which illuminates the world. Dear participants, do remember that the time given to you for presenting the paper is only 5 minutes, and 1 minute is for question and answers. We have 5 participants scheduled for this slot. I will read out your names now. Please do acknowledge your presence in this meet, either by raising your hands or by posting a message in the chat box. Dr. P. Parimala, Dr. Vinodini, Veena Shri, Narayani Nivedita, and Rashmi Gopalakrishnan. Meanwhile, I would like to invite Professor S. Vaidehi, Department of Biochemistry, to introduce the chairperson, Dr. M. Sujata. Ma'am, please.
With immense pleasure, I welcome the chairperson for this session, Dr. M. Sujata, Dean of Academics, Ithiraj College for Women. She is a dynamic personality. She has rich experience of more than 25 years in teaching and research with specialization in immunology. She has acted as camp officer and chief superintendent for conducting end semester examination during the tenure of 2012 to 13 and 2015 to 16. She has been the staff secretary during the year 18 to 19. Added to her credential, she is also one of the project proposal scrutinizing committee member in National Biodiversity Authority of India. She is also a member in various boards, organization, interview and selection panels. She has completed 2 management-sponsored research projects. She has chaired many sessions, served as judge in many national and international events. A very warm welcome to you, ma'am. Sujata, ma'am, please take over the session, ma'am. Sir Selvaraj, sir. Sir, please stop sharing your screen, sir.
Okay.
Thank you, sir.
I stopped the video.
Thank you, sir. Ma'am, Sujata, ma'am.
I have unmuted myself now. Okay, okay.
Good evening, ma'am. So
Yeah, good evening.
Shall we start with the program?
Yes, ma'am. Yes, please.
Okay, so the first participant is Dr. P. Parimala, who will be talking on the topic ascertaining phytotherapeutic efficacy of Acorus calamus root infection on diseased koi crab.
Ma'am, Sujata ma'am.
Yes, ma'am.
Ma'am, you have to stop sharing your screen, ma'am.
Yeah.
Thank you, ma'am.
Good afternoon, ma'am. Good afternoon, ma'am. Am I audible?
Yes, ma'am, please.
Yes.
I can hear you. Please continue. Yeah.
Yes, ma'am. Good afternoon, ma'am. I am Dr. P. Parimala, Assistant Professor, Department of Biochemistry. Yes, ma'am.
Parimala, ma'am. Ma'am,
Yes.
I just want to tell again that the timing is 5 minutes for paper presentation and 1 minute will be for question and answers. After 4 minutes, there will be a short bell. After 5 minutes, there will be a long bell, beyond which you will be muted.
Okay, okay, ma'am. Okay.
Okay.
Okay, thank you, ma'am. Shall I start?
Yes, ma'am, please.
Yes.
Okay, I'm here to present my topic entitled Ascertaining Phytotherapeutic Efficacy of Acorus calamus root infusion on diseased koi carp. Why this study? We know ornamental fish production is an important component of the aquaculture industry because their contribution is important and play a vital role in the economy of both developed and developing countries. They were called as living jewels because they were available in wide fanciful varieties. However, their maintenance is difficult because due to the poor water quality serves as a chief factor in developing many types of fish disease, which includes white spot disease, mouth fungus, tail, and fin rot, etc. We know various therapeutic aids are available, which includes antidiabetics, disinfectants, chemotherapeutic drugs. However, their use is not advisable because they may be involved in the development of drug-resistant strains. So they are not advisable. So we have focused to find the therapeutic aid of natural sources, that is the phytotherapeutic agents, because they have various advantages. They are economical, effective, non-resistance farming, renewable, eco-friendly, and farmer-friendly. So we have chosen to study the phytotherapeutic efficacy of Acorus calamus. Next, aim and objective. Coming on to aim and objective, we have used koi carp as the experimental animal because we know koi carp is one of the important ornamental fish in terms of economical value and also is often found to challenge disease in the environment. And we have used roots of Acorus calamus as the phytotherapeutic agent because roots of Acorus calamus is well known for their medicinal properties such as wound healing property, anti-diabetic activity, hepatoprotective activity, and various antimicrobial property, which includes antibacterial, antifungal, and antiviral property. So we have chosen roots of Acorus calamus as the phytotherapeutic agent, and we have used to test the physical characteristic of fish, which includes length, weight, and number of fish survival, and what is the impact of this extract on the disease characteristics. And also we have studied the oxidant and antioxidant status in muscle homogenate. This is the Cyprinus scorpio. This is called as koi carp, and this is the Acorus calamus. Its scientific name, it is commonly called as sweet flag, and in Tamil it is called as vasambu. Coming on to materials and methods, we have used Acorus calamus to study the phytochemical value. Phytochemical analysis was carried out on the roots of Acorus calamus, and based on the health of the fish, fishes were classified into 4 groups: control, that is the healthy fish, and test, which includes the diseased fish, and treatment 1 and treatment 2. Treatment 1 was given with the 1% Acorus calamus, that is our phytotherapeutic drug, and a 0.25 tetracycline was used as the drug, which is the well-known synthetic drug. It is the commercially available drug and well known for its anti-diabetic activity, which was given as the standard drug. It is given as the treatment to, and all these 5 groups were studied for their physical characteristics, which includes rate of survival rate, weight, length, and disease characteristics were also studied. And from all these 4 groups, muscle were excised and homogenized and used for the assay of oxidant and antioxidant assay. Oxidants includes lipid peroxidation assay and antioxidants includes SORD assay. Superoxide dismutase and catalase. Then coming on to results and discussion, we have noted presence of various phytochemicals, which includes glycosides, phenols, tannins, flavonoids, steroids, and terpenoids, and also found absence of anthraquinones and quinones, xanthoproteins. And coming on to the biochemical parameters, which includes the physical characteristics, length and weight. Both initial weight and after 4 weeks, length and weight were noted, and they were found to be, at the initial time, they were found to be similar, but after 4 weeks, after the experiments over, we found there is a decrease in the length of the fish and weight of the fish in the test condition, and on treatment 1 and treatment 2, they were found to be increased, both length and weight. Coming on to survival rate, decreased survival rate was found in test fish when compared to other 2 conditions, and lipid peroxide, increased oxidant and decreased antioxidants was found in test fish, that is the diseased fish, and decreased oxidant and antioxidants was found in treatment 1 and treatment 2. It shows that increased demand for antioxidants during diseased state and decreased demand for antioxidant because there was decrease in the oxidants in the treatment 1 and treatment 2 condition. Summarize. Overall, we summarize that fish tanks infused with Acorus calamus showed significant alteration in terms of physical as well as biochemical parameters in diseased fish when compared to other groups. So our study reveals that roots of Acorus calamus exhibits the beneficial phytotherapeutic efficacy in rendering recovery of fish from disease. So which may be ascribed to the phenols, tannins, flavonoids, glycosides, and terpenoids present, and it may be recommended as the effective therapeutic components in the aquaculture industries for both prevention and treatment measures. Further characterization and purification of the individual phytochemical is necessary to validate its effect, beneficial effect during the disease in the fish. Thank you, ma'am.
Thank you, Paramada, for your nice presentation. The
Thank you,
presentation was really good. I
Thank
have a
you,
question.
Yes,
Like, did you, induce the disease?
No, ma'am. We have collected the diseased fish, ma'am. We have noted a disease such as a white spot is there in the fish. We can see the white spot, and also tail and fins were rotten. And also we have noted a cotton-like outgrowths that were selected as the diseased fish.
So different types of diseases. It is not only one particular disease, no?
Yes, ma'am. Yes, ma'am.
Okay.
Different types of disease. Physical appearance, based on the physical appearance, ma'am.
Only physical appearance. Okay.
Yes, ma'am.
So what are the causes for those diseases in the fishes?
Mostly microorganism, ma'am. Infection mediated diseases are there, ma'am. Many microorganisms are there in the water. We know pollution is there. We are using the polluted water also for the fish production. That poor water quality may be attributed to this type of fish disease, ma'am.
So you are going to say that that instead of antibiotics, these antioxidants will help in combating the infections.
Yes, ma'am. Yes, ma'am. Because antibiotics may develop disease-resistant strains, ma'am. So
it is for the prophylaxis, that is before the disease or after the disease also it is curing without the antibiotic.
Yes, ma'am. Yes, ma'am. Because it is a herbal origin, we can use it, ma'am.
Okay. So what about the severity of the disease? So how will you analyze the severity of the disease, ma'am?
It will show motility, ma'am. We can see, we can observe there is less movement.
Do you have any parameters to assess the severity of the disease? Mild, moderate, and severe. Is there any parameter? Because we do not know, in fishes. Is there any yardstick to know the disease state?
Physical characteristics only we have seen, ma'am, and also oxidant and antioxidants we have seen, ma'am.
Okay. So it is improving the antioxidant status as well as the it
reducing
is improving the symptoms. Okay.
Yes, ma'am. Yes.
Okay. Okay. Thank you.
Thank you, ma'am.
So can we have the next contestant?
Yes, ma'am. The next participant is Dr. Vinodini, who will be talking about antibacterial, antitubercular, and antioxidant activities of bioactive compounds obtained from hexane extract of tuna ciliata leaves.
Do I have to share the screen or?
Yes, ma'am.
Yeah, please.
Yeah, just a second.
Vinodini, ma'am, you're on mute. Please unmute yourself.
Start. Yeah, good afternoon to one and all present here. My study is regarding the antibacterial, antitubercular, and the antioxidant activities of the tuna ciliata leaves. Why this tuna ciliata? This tuna ciliata belong to the Miliaceae family. Basically, most of the plants from this family have showed promising results in most of the activities. So I chosen this with the previous literature survey. I chosen this tuna ciliata. Then why leaves? Since leaves are the renewable source, I selected leaves as the part. My objective of the study is to isolate. Earlier studies with the tuna ciliata have been done mostly with the extracts, food extract. So I thought we'll isolate the bioactive compounds from the bioactive principles from these leaves and thought of testing these activities. 3 biological activities I tested. And one is first is the antibacterial activity against 6 bacterial bacteria species I tested. Then anti-tubercular against 3 strains of mycobacteria I tested. Then antioxidant activity with the commonly used 3 types of antioxidant assays. With the further characterization with the bioactive principle was further characterized using the spectroscopic methods. Then extracts, with the cold percolation method, the hexane extract has been prepared. Leaves has been shade dried, and with cold percolation method, the extracts have been obtained and they were tested for the phytochemical activity, phytochemicals which are present here. Except alkaloids and glycosides, most of the other phytochemicals have shown the presence. So then column chromatography, and it has been shown with the hexane fractions. These are the RF values of the hexane fractions. Then these are the TLC plates that have been obtained. Now the biological activity, antibacterial activity was tested using a different assay, the resorcent antibacterial assay. Then anti-tubercular assay has been performed using the method luciferase reporter phage assay. And as antioxidant, the commonly used PPH assay and H2O2 scavenging assay. Then reducing power assay. Now, why this resorcent associated? Resorcent included assays. This resorcent is a blue indicator. When the viable cells are present, they are able to reduce them and make them color change to pink color. So this resorcent has given promising results and been widely used MIC technique, which we are able to obtain the MIC results. So this result, when the cells are died, when we inculcate this bioactive principles, 4 fractions which have been obtained, they are able to produce they are able to kill the microorganisms, bacteria, and they are able to stay with blue color. So, and the bacterial strains which are used are E. coli, Proteus, Enterobacter, and the Salmonella typhi, Bacillus subtilis, and Staphylococcus aureus. Why antibacterial activity is antibacterial activity? Because of the erasal of resistance, antimicrobial resistance is being more common nowadays. So I thought of doing this antibacterial assay. Then anti-tubercular, there's now XDR-TB has come after MDR-TB, now XDR-TB has come. So the search for the newer bioactive principles has made me to do this anti-tubercular activity. And this is the first time anti-tubercular activity has been reported with this tuna ciliata leaves. So against 3 strains I tested. One is sensitive strain, that is the first line drugs which are being used conventionally in the treatment of tuberculosis. These are Mycobacterium tuberculosis, which is sensitive to those first line drugs and which are resistant to those first line drugs, and the standard strain, which is also being included in this study. And the results are being obtained as relative light units. Then antioxidant assay, the ability of the antioxidant, the bioactive principles which are being obtained, how they are able to decrease able to reduce the DPPH has been assessed, and hydrogen, how they are able to quench or able to scavenge the hydrogen peroxide capacity has been assessed. Then reducing power, the ability for them, bioactive principles, how they are able to reduce the ferret form to ferrous form is also being assessed. These are the results obtained. Antibacterial assay using the REMAP assay. So these are the results. And with this, the most promising results has been seen with H1 against E. coli and H2, H3 against E. coli, and with H4, they shown promising effect against Staphylococcus aureus. With anti-tubercular activity, when the drug is able, when the compound is able to produce more than 50% of reduction, then they are being considered as anti-tubercular compounds. With this, H4 is showing, the fraction H4 is showing a promising results against a sensitive strain, and H3 and H4 are showing a very good effect against these resistant strain, which is a very good promising result. Then again, standard strain, again H3 and H4 are showing a promising result. With the antioxidant activity, with DPPH assay, none of these are showing promising results. Whereas with hydrogen peroxide, the crude extract is also being included. So that has shown the promising, a very good effect when compared to the, compared to the standard which is being used. And reducing power assay H3 and H4 has been shown. So with the spectroscopic analysis with the FTIR, HNMR, and proton NMR, and carbon NMR, and mass spectra, these are the characterization principles. And with this, we have obtained this results. And the possible structures of the drugs, the compounds are also being proposed. And these are the proposed structures of the compounds which have been obtained from the exit fractions of the tuna ciliata leaves. And this session, with this, these are the activities which have been already reported, and almost all the activities are already been reported only with food extracts. So I was able to obtain 4 active principles from there. Among these 4 active principles, H3 and H4 are showing promising result in against tuberculosis, and H4 is showing a very good effective result against the bacterial strains which are being used. So with the further analysis and characterization, these drugs can, so these compounds can be developed as a promising compounds, lead compounds in the treatment of the infections or the diseases. Thank you.
Thank you, ma'am, for the wonderful presentation. And
thank you, ma'am.
The work was really good. You have worked extensively. Thank you so much for that. And what is the common name for this thing, for tuna ciliata? What is the common name?
Malayvembu. Malayvembu.
Malayvembu. Okay.
Yeah. Similar to Nilu.
Similar to? Sorry.
Nilavembu. Same
Nilavembu. Oh, okay, okay. Yeah. Similar to Nilavembu. Okay.
Yes.
So what would be the probable mechanism by which, because it is combating gram-positive and gram-negative on all the mycobacterium, what could be the probable mechanism?
That has to be studied. Maybe
yes, ma'am. Do you have any, because usually, it is very difficult to combat all sort of infections, isn't it?
Yes.
But
yes.
It is alleviating almost all sort of bacteria. Okay, because mycobacterium is very tough to eliminate. So, is there any other speciality in this particular herb, ma'am? Because it's very strong enough to do all the functions.
Yeah, is there any other? It was shown that flavonoids, which are being present, are showing promising results against the bacterial strains which are being used. When the flavonoids are having very good effect, and I think probably by destroying the cell wall, they are able to act very effectively. That might be the probable mechanism.
But flavonoids are all, they're all present in almost all the plants, no ma'am. But flavonoids, and they're generally present in almost all the herbs we use, no ma'am. So what's the speciality in this particular species? Do you have any review paper, saying that this particular thing it has got a peculiar phytochemical or group of phytochemicals which can combat these infections?
No, ma'am. That's what crude extract. They have told that it is widely, mostly it is predominantly the presence is with flavonoids. They have reported.
Okay.
But most of the roots, they have told that, or even though all the other phytochemicals have been reported, the phytochemical which is more predominantly which is present is flavonoids. That's what has been reported so far. So we have tested, shown the presence. Maybe with further characterization, we will be able to come to a conclusion.
Because you have mentioned all the usual phytochemicals, so I was very curious to know. So how come this, that is, it can combat all the infections. Thank you so much, ma'am. Nice presentation.
Thank you. Thank you. Thank you.
So, ma'am, shall we move on to the next participant?
Yeah, yes, ma'am.
Okay. So the next participant is Veena Shri. She'll be presenting on the topic Evaluation of Efficacy of Mukhya Madrasapatana in Phytoremediation of Ayapakam Lake Water. Veena Shri, are you there?
Yes.
Yes, okay. We will share the presentation in a minute. Please wait.
Good afternoon, everyone present here. Myself, K. Vinastri. I am from BG Vaishnav College. My research topic is about evolution of efficacy of Mukhya Madrasapatana in phytoremediation for Ayapakam lake water. Next slide. Water is the most essential thing in our day-to-day life. Water pollution is due to the overpollution, industrialization, and urbanization. This leads to the effect in food chain. Next. This leads to various waterborne diseases, and the methods to control this disease are physical, chemical, and biological method. Over this biological method, phytoremediation is majorly taken by us. Next. We took Mukhya Madrasapatana is used for the phytoremediation in polluted water, and it is commonly known as musmuska in Tamil. And it cures skin diseases, kidney stones, and acts as an anti-inflammatory. It gives a nutrients like alkaline flavonoids. Next slide. The research area is Ayapakam Lake, which is situated in Tiruvekadu Road. The main reason for choosing this lake as a research area is that sewerage is let into the lake by the neighboring housing board tenements. This gets deteriorated. So to avoid the further deterioration, water is collected from this lake. Next slide. The main aim and objectives is that one, to carry out preliminary UV absorption studies, two, to analyze the physicochemical parameters of the water sample, three, to estimate the bacterial profile in the water sample, four, to determine the chemical metal concentration, five, to explore the phytotoxicity of the water sample by using a seed germination test. Next. Materials and methods: to collect the water sample from a lake area and then stored in refrigerator at 40 degrees Celsius, and leaves were the Mukhya Madrasapatana leaves were put it in a dry shade, and then it was removed by surface contaminants and powdered and blended in a container. Next slide. The experimental setup is made by using 1 liter capacity of beaker. Two beakers were taken. One is filled with the distilled water, and next one is filled with the polluted water. And performing various experiments on trial basis, 10 mg of leaf powder was added and stirred for 10 minutes. Retention time is 1 hour for each experimental setup. Next slide, please. Comes to the results and conclusion. From the UV absorption, the results are showing the from 100% polluted, that is untreated water, shows the higher concentrations in various nanometers wavelengths, 200 to 350, and then in a powder leaf, after the treatment with the powder leaf, it shows some efficacy effective values, and then from fresh leaves, it is much better values than the powder leaf. Next. And then physicochemical parameters, from that turbidity and the electrical conductivity, TSS, TDS, total alkalinity is much better than the polluted water as shown here. Next slide. Next slide, please. And the magnesium hardness, iron, sulfate, carbonate hardness, and then magnesium are also reduced than the polluted water content. Next slide. BOD and COD, biological oxygen demand and chemical oxygen demand values are noted here. From COD, it is slightly varied in treated water, getting better, slightly different. And then for the heavy metal concentration of the untreated water is shown here. Next slide. The lead concentration of the treated and untreated water sample is shown here. For the untreated sample, it is 25.55 in value, and then the treated freshly values are much better than the untreated value, 16.73. Next slide. These are the microbial content of water sample from the study area are shown here in the table column. Next slide. We do a phytotoxicity study to know that this untreated water affects the plant or not. It is shown that the control here, the control distilled water is taken as a control, and then second untreated water. The untreated water is 20% ineffective. The treated water, it is 50%. By calculating using a number of seeds germinated divided by number of total number of seeds into 100, we are getting this value. It is much more effective in treated water. Next slide. Conclusion. The present study, based on the physicochemical analysis and phytotoxicity studies, suggests that Ayapakam lake water is not suitable for drinking purpose. Further, it shows that mucium atrosepena leaf powder is effective in reducing TDS, COD, and lake concentration in water sample from Ayapakam lake. Hence, it is concluded that mucium atrosepena can be recommended for wastewater purification. However, the present study must be suggested to carry out on a large scale to confirm its efficacy. Thank you for your presence.
Thank you, Ma, for the presentation, because of this, you focused mainly on the environmental issues. It is very good to have this kind of papers.
Thank you, ma'am.
And so you are telling that after this treatment, the water became potable, right?
Yes. Yes.
Okay.
It's not much, but slightly
Okay.
it is better.
Slightly, it can reduce the heavy metals,
Yes,
and also, some of the microorganisms were reduced, isn't it?
Yes, ma'am.
Okay. So, did you check the level of heavy metals in the plant, Ma? Because after bioremediation, did you check the levels of the heavy metals
Heavy
in the
metal?
plant?
Yes, ma'am. Lead only we are checking, ma'am, because other components, other heavy metals are higher in cost effective. So
You didn't do that. Okay.
Yes.
So you check only with lead. So what method you used, Ma, to check the lead? What is the methodology used?
Yes.
What is it? The spectroscopy, atomic absorption,
Yes,
or what is it?
Spectroscopy.
Okay. What is the unit for that PB? You didn't show it in that table column, no?
Yes.
What is the unit? It is ppm or ppm, like that. What is it?
ppm.
It is ppm. So what is your conclusion, Ma? So you have done all these experiments, and you are telling that it has decreased the TDS and all those things, and
Yes,
also it has improved all BOD and COD. Everything is fine. Okay. So what do you want to conclude it?
We are doing it in 10 mg, ma'am. 10 mg in concentrations. We suggest to do this in large scale. For doing it in a large scale, it shows much more effective.
Okay, but you have not done the other heavy metals. You have done only lead. You didn't do
Yes,
cadmium, arsenic, and all due to the cost,
yes,
isn't it?
Yes, ma'am.
Okay,
yes,
ma. So later you can do all this. Okay.
Okay.
Okay. Thank you.
Thank you.
Shall we move on, ma'am?
Yeah, sure.
Okay. So the next participant is Ms. Narayani Nivedita, who will be talking about preliminary phytochemical screening and TLC profiling of various extracts of Anisomylis indica. Ms. Narayani, are you here?
Hello. I've unmuted, Ma.
Yes, you are audible now.
Yeah, yes, ma'am. Good afternoon, all of you. Should I share my screen or will you be showing it on the screen?
Yes, ma'am. Can you share your screen? If
Yeah.
not, we will do it.
Yes, ma'am. Yes, is my screen visible to everybody? Hello?
No, ma'am, it is not yet visible.
Sorry. Can you just
Do you want us to share it?
Yes, ma'am. Please, can you?
Okay, please give us a minute. We'll share it.
Yes, ma'am. Hello? Hello? Hello?
Yes, ma'am, we can hear you.
Oh, okay, ma'am.
But we are not able to see your screen yet, okay?
No, that's what.
Yes, ma'am. We will be sharing it in a minute.
Okay.
Please wait.
Yeah. Yes, thank you so much, ma'am. Can I start my presentation?
Yes, ma'am.
Please.
Yeah, good afternoon. First of all, I'm very grateful to the host for having included me in this session. I extend a warm good afternoon to the chief guests and one and all present. I want to do a presentation on a preliminary phytochemical screening and TLC profiling of the different extracts of Anisomeris indica. This is the plant of my study. This is a part of my research work, and it's a very preliminary work, of course. But I've done my part of it. I've presented over here, so that it will help me in further separation of the active components. Next slide, ma. Next slide. No.
Next slide, please.
Technical team, please change it to the next slide.
Yes, next slide. Hello.
Yeah, we can hear you, ma'am. Please continue.
Okay, yeah. So this plant, Anisomeris indica, it's a traditional medicinal plant, and only now some work has been reported earlier in 2008 and 2007, and now it is currently being studied, and recently it has been widely being used. So I thought of taking this as a plant for my study. My main work was to find out the phytochemicals present, so that phytochemicals are the basic compounds which are responsible for the antibiotic, antifungal, and antiviral properties. And so, by doing the screening of the phytochemicals and the next step, TLC, I thought I can identify and try to pinpoint the main phytoconstituents responsible for the medical activity of this plant. And next was to do a TLC so that I could find out the how to set up the suitable solvent system for the separation of these main phytochemicals. Next slide, now, please. Right. Yes, ma'am. Anisomeris indica is commonly known as Indian catmint, belongs to the Lamiaceae family, and already by previous review of literature, I've seen that it is rich in medicinally active compounds and various antioxidant, antimicrobial, and anti-cancer activity, analgesic activity, anti-inflammatory activity has been reported, and the whole plant has been reported for medically important activities. And so I've taken the whole plant as for my study, and made this particular study, which I've shown here, is only a basic study on doing a phytochemical analysis and TLC profiling. Next one. Yes, this is just a view of the plant. It belongs to the Lamiaceae family, and the botanical name is Randomised indica. Another synonym for it is Anisomeris ovata, and common name is Indian catmint, and this vernacular name is Vattasaraj. Yes, my next slide. Yes, as I've told earlier, this is I've used different solvents. I've taken the non-polar and mid-polar and polar solvents. I've chosen 4 solvents so that I wanted to see the different type of phytochemical profile which could be derived from this different solvents of varying polarities, and then to perform a TLC of the crude extract before I could go in for the component biocomponent separately. Next slide. Yes, I've taken the plant from the Dindigul district in the month of October, November. Then I've given it for authentication from Professor Jayaraman of Presidency College. And then I went in for preparation of the crude extract. I had prepared lots of crude extract, but for this particular study, 50 grams was sufficient. So I took 50 grams and I did the sequential Soxlet extraction method. And I've used 4 solvents, starting from the non-polar hexane to the mid-polar acetone, and finally the ethanol and methanol solvents, which are more of high polarity range. I started my extraction. I carried out the extraction for a week or so till the limb of the Soxlet, the solvent became colorless. At the end of the extraction, I reduced the solvents in the rotary vacuum evaporators till I got a semi-solid paste. This semi-solid paste I used for my phytochemical analysis. Next slide. Yes, this phytochemical analysis, these were the procedures. For alkaloids, I've done the Wagner's carbohydrates, Benedict's test. Saponins, I did the home test, steroids and flavonoids, phenols, ferrichloride test, steroids. I've done the Salkowski's test, and amino acids and anhydride proteins and biuret, and terpenoids. Again, I did the Salkowski's test. And these are the general observations. Next slide, please. For the TLC profiling, I took the at the end of my studies, phytochemical studies, I found that the ethanolic extract was rich in the phytochemicals in some of, especially the acetone, especially the alkaloids, phenols, and flavonoids were present in much more concentration in my TLC, in my ethanol extract, and also in my methanol extract. So I've taken this TLC, ethanol extract, and in my TLC. Hello. And the TLC, I've main aim of my TLC, I've subjected to 4 different solvent systems. One was a butyl acetic acid water, the other one hexane, ethyl acetate, chloroform, and methanol. They were used in different ratios. And after developing the TLC plate with the spots, I've sprayed it with different reagents for identifying the respective phytochemicals, namely alkaloids, flavonoids, phenols, and terpenoids. Next slide, please. Yes. So in my study in phytochemicals, I found that the methanol and the ethanol extract consisted mostly of all the polar phytoconstituents like the alkaloids, phenols, and flavonoids. And whereas the acetone extract, very less of it was found. Next slide, Ma. Next slide. Yes. The hexane consisted of very little amount of alkaloids and terpenoids. Ethanol and methanol consisted of all alkaloids, terpenoids, flavonoids, and phenols. The color also was dark.
Narayani ma'am. Narayani ma'am, I'm
Yes.
sorry for the interruption.
Yes.
Ma'am, can you please go to your conclusion slide, ma'am?
Yeah,
You're taking 6 minutes.
The crew has to go to it because I've just been shared by the. I'm not.
Yeah, I know. They are moving it. They're unable to hear you. That was the reason there's a delay in moving the slide.
Okay. The final.
You want any other slide before this one?
Pardon? Yeah, the
Is there any important slide that you would like to?
Yeah, TLC plate, TLC results. Yeah, these are the tables. Yeah, the TLC fingerprint profile. These are the under UV light at 254 nanometer, and phenols, alkaloids, and flavonoids. All these shows that only the butanol acetic acid water system has evident in the UV light gives a very good profile. So I've decided that butanol acetic acid water is the ratio 4:1:2 gave the best separation, and I could use it for further more studies. This is my conclusion. Yes, it can go to the conclusion slide. Yeah, so I plan for furthermore studies for the bioseparation, and this is only a preliminary step. Thank you so much. Yes,
Thank you, ma'am. You have presented extremely well. And my question here is, as far as the TLC profiling is concerned, you have mentioned that in one particular combination, maybe butanol lactic acid mixture showed very good, excellent results. Okay.
Yes, ma'am.
So why did you choose this? Because they have been, screening this TLC, using the TLC. Okay. So why particularly you choose this particular plant? Is there any reason behind it?
Yes.
Apart from the therapeutic thing, is it a newer plant or is there any?
Yes, ma'am. Actually,
is novel to it.
Actually this plant it is I studied as far as the extensive after the extensive survey literature survey. I found out only some cell line work has been done. In vivo animal models have not been used in any of this in this plant study. And plus many it has got many activities as after the literature survey, and only cell line work has been done. I wanted to do an animal study in depth and also find out more compounds. It is being current. That's why I've taken this plant now.
Because they have not screened it.
Animal study, no, ma'am. Very less work. Only cell line work is being gone. As far as I've searched.
No. You forgot about the animal study. That is going to be the next part of work.
Okay, ma'am.
Talking about this part of work, ma'am, they have not screened already this particular. Okay.
They have done screening, but different solvents have been done and different compounds have been identified. But I wanted to identify, and it is a relatively new plant with not much literature available.
Okay.
So I thought I could do a much more thorough work on my own. That's why I thought I would choose this plant.
Okay, ma'am. Okay, good, ma'am. Okay.
Thank you very much.
Thank you. Thank you.
Okay, so there's one more participant. It is Rashmi Gopalakrishnan. She'll be presenting on the topic preliminary study on L-asparagine enzyme producing actinomycetes isolated from Western Ghats. Ma'am, are you there?
Good evening. Am I audible?
Yes, ma'am, you are.
Can you please present the screen because the rain, some technical issue. I'm not able to connect through my laptop.
Okay. Please wait a minute. I'll tell the technical team to present it.
Okay. Thank you.
कि मुझे ऐसा कोई काम फेंक के जो हो भी जा
Okay, shall I start the presentation?
Yes, ma'am, please.
Good evening to the resource person, Dr. M. Sujata, and all the other co-participants. My work is on preliminary study on L-asparaginase enzyme producing actinomycetes isolated from the Western Ghats. So my co-collaborators for this work is Dr. B. Tamari Selvi and Mrs. K. Madana Sundareshwari, from the Department of Microbiology, Sri Ramakrishna College of Arts and Science in Coimbatore. As we all know, Western Ghats, next slide. As we all know, Western Ghats is known to be a very active hotspot region, and it has got a diverse biological flora, like it could be plant, animal, and especially microorganism, and it extends from different states, starting from Gujarat till Tamil Nadu. And already a lot of study has been done in Western Ghats area, particularly on like bacteria, fungi, actinomycetes, but most of the actinomycetes have been explored for isolating antibiotics or other like some other products. So here my work, next slide. So I have chosen this work. The enzyme is L-asparaginase. So L-asparaginase is actually an enzyme which is the mechanism of this enzyme is, as we know, tumor cells. The tumor cells, they require the enzyme L-asparagine. It's an essential enzyme, and this enzyme is needed for the growth. And as we know, tumors are uncontrolled population of the cells. So they use this L-asparagine and they grow tremendously. So this enzyme, L-asparaginase enzyme, what it will do is, it will break the asparagine in the tumors to aspartic acid and ammonia. And this way, it will cut down the supply of L-asparagine to the tumor cells, by which the tumor cell growth will be inhibited. So already we know a lot of microorganisms are there which are explored for a lot of metabolites. It could be in the form of an antibiotic, vitamins, enzymes. So here it has been found in the literature that L-asparaginase is used in a multi-drug therapy for treating cancer, especially ALL, acute lymphatic leukemia. Why I have chosen actinomycetes is because the work has been already done using bacteria and fungi. The bacteria and fungi has been explored, or it has been used to isolate the L-asparaginate. But this L-asparagine enzyme, which is used from bacteria or fungi, they contain as glutaminase. So this glutaminase has got some adverse effects when it is given when it is purified from a bacteria. So that's why actinomycetes are more and better option for isolating L-asparaginase enzyme. So this is very preliminary work where I have tried to collect soil samples from next slide. Yeah, objectives. Yeah, so I have tried to isolate the soil samples from different areas, starting from the like different areas of the Western Ghats. I have collected soil sample from Goa, Karnataka, Tamil Nadu, Kerala, and all. And I've just tried to isolate, like I've done the two screening. One is preliminary screening using a method called as rapid plate assay method, and another one is a secondary screening by nestlization method. Next slide. So here, I think next slide. So here, very simple process of serial dilution. The soil samples serial diluted. They were inoculated on starch casing agar, and the actinomycetes colonies, the typical colonies were picked, and they were undergone gram staining was performed. As we know, actinomycetes are gram positive filamentous bacteria. Next slide. So preliminary screening was done by a method called as rapid plate assay method. I think I can go to the slide next. I will just show the plates results. Next. Next slide. Yeah. So these are like total. Okay, thank you. Totally for 12 soil samples were collected from different regions of Western Ghats, and after that, I could isolate 35 actinomyces strains, and that for typical colonies of actinomyces strains I've selected, and they were screened for L-asparaginase activity. So out of that, 8 strains were positive for L-asparaginase. So these are some of the plates. Next. So this is a rapid plate assay method. It's a preliminary screening method to find out whether the actinomyces has got L-asparaginase activity is produced by this actinomyces or not. So it's a medium where phenol red is incorporated. As already told you in the mechanism, asparaginase is an enzyme which could hydrolyze asparagine to release aspartic acid. So aspartic acid, it's an acidic product. So you can see a pink color.
Participants, please mute.
Yeah. So because you can see a pink coloration in the surrounding this, because asparaginase enzyme, because so and if antigen is produced, it will acid. Acid is a pink color because of the phenol red. Next, I have done a secondary screening by nasalization method. So nasalization method, same, how much ammonia is released, that is only calculated, and with that there's a formula to find out the enzyme activity. So out of the 8 strains, I could find some of the strains have, when I compare with the literature, I could see some of the strains have given an excellent result. So the future prospect of the work is further this lead molecule, which is asparginase enzyme molecule. It has to be carried for purification by column chromatography. Molecular weight has to be determined, and to confirm this L-asparaginase has got an anti-cancer and antioxidant activity, so that it will be an application. Thank you, ma'am.
Sujata ma'am, you're on mute.
Can you hear me?
Yes, ma'am.
Okay, so ma'am, so you have isolated 8 strains, out of 35 strains, and the 8 strains, they showed good results on L-asparaginase activity. Very good, ma'am.
L-asparaginase positive, ma'am.
Yes, yes. So you have used the nasalization method. No? Is there any other method, which assesses the level of asparagine, ma'am? Or this is the only gold standard method for the estimation of asparaginase?
No,
Why did you choose
ma'am.
this?
It's actually no, ma'am. Why? Because it's easy to use method. It's very quick in our lab, ma'am. Maybe if we have to study further about the enzyme, we have to go for a molecular study. So that's future prospect, ma'am. With a simple nasalization method in the lab, visible method, I've just tried, ma'am. Because rapid assay method have given only acid starvers. So the organism is able to produce the asparginase enzyme, then only it could cleave that asparginase and it could release the aspartic acid, which is indicating with the help of the phenol. So
you have already
study, ma'am, actually.
You have quantified that also, no? You have quantified.
If I have found the activity by a nasalization method, but further I have to work on it, ma'am, because it has to be taken for like molecular study, like column chromatography purification, and then
you are going to going to use any animal or cell line, no, ma'am, to do the anti-cancer work?
Yes, anti-cancer activity, I have to use a cell line. Maybe a good for animal study. This is just a lead molecule, I guess now I've got.
Okay, good, ma'am, good. Very good presentation, ma'am. Thank you so much. Thank you.
Thank you, ma'am, very much.
So, ma'am, with that, we have come to the end of the presentations. Can you please share your opinions about the session with us, ma'am?
Yes.
Okay.
Good afternoon, good evening, all of you. And I would like to thank Dr. P.T. Srinivasan, Head of the Department of Biochemistry, DG Vaishnav College, and also co-convener for this conference. And also I would like to thank Dr. Sangeeta, Ms. Maidegi, organizing secretary of this conference, and also the crew members of especially the backbone of Biochemistry Department. I would like to thank each one of you. And as far as this particular paper presentation is concerned, and all of them have done it extremely well, and my heartfelt congratulations to all of you. And as far as the phytochemicals are concerned, and we know that it is antimicrobial agent, and it has got anti-inflammatory property, and it has anti-cancerous activity, and it can change the metabolism, it can modulate the metabolism and stimulate the immune system. And we know what are the various phytochemicals, and we do all the qualitative and quantitative analysis using the phytochemicals. But the exact mechanism behind that is anti-cancer activity or anti-microbial. So how does it actually exert the effect is not studied extensively. So we have to work on it, and especially with the molecular mechanisms to be studied extensively, because we call the phytochemicals as a two-edged sword, because we have to use it very carefully, because what happens when it is not used properly, it is going to be highly toxic to us. So the molecular mechanisms may be explored in future. So with this, I would like to thank all the students for the patient hearing, and also the staff members, and thank you so much for the opportunity. Thank you.
Thank you, ma'am. Thank you for being with us.
Thank you, ma'am. I now request Vaidehi ma'am to take over the session and conclude it. Ma'am, please.
Thank you, Jamie. On behalf of our department and my own, I wish to thank you, ma'am, for accepting to chair this session. Thanks for your time, ma'am, and enthusiastic scientific deliberation for the last 40 minutes. I am sure your comments and queries would have enriched the scholars with better ideas to take their work forward. Thank you, ma'am. Thank you, participants. Thank you all.
Thank you, ma'am.
Thank you, ma'am. We have come to the end of today's session. Hope this session was very useful to all. Tomorrow, 19th October, holds for you 2 more plenary lectures and a packed session of paper presentation. We request you to kindly join tomorrow's session by 9:45 a.m. As tomorrow is a holiday, you may find it convenient to attend the conference from the comfort of your home. The feedback link for the 2-day conference will be available at the end of the valedictory session. The best paper and best poster awards will also be announced during the valedictory session. Hope everyone had a nice day. Stay safe, stay connected. Thank you.